First of all, I'd like to thank you guys for inviting me here today. And I want to start by discussing some pearls for management of some of the common pediatric disorders. We're looking at who's at risk as we talk about the tridemic and some of the impacts associated with it. And I'm going to make sure okay. So our objectives today, guys, we're going to be talking about or identifying some of the common medical disorders affecting children and adolescents. We want to be able to describe the tridemic, and treatment plans, and then discuss management of some of the common pediatric disorders. As we talk about these disorders, recognize that a lot of the disorders that we're talking about today are viral disorders. So that's going to significantly impact how we treat them. I have no disclosures, and once again, I want to thank NPACE for inviting me here today. Every time I give talks similar to this and anything pediatric-oriented, I feel the need to talk about prudent prescribing, recognizing that as healthcare providers in the room, we all recognize the importance of prescribing prudently, not over-prescribing antibiotics, especially as we talk about the common viral disorders that we'll discuss today. There's concerns regarding antibiotic resistance, recognizing that during the last season, there were some antibiotic shortages. So really reinforcing the importance of appropriate prescribing of these antibiotics. I don't know about you guys, but in my healthcare environment, because one of the things I've done is work in an urgent care center, many times the parents would come to me in the urgent care center after seeing you guys in the family practice or pediatrician's office asking me for antibiotics. So then I had to do what I'm asking you guys to do, and which many of you guys had done. They thought they'd be able to come to the urgent care and just say, pay their money and buy the antibiotics. So really important to provide the education, recognizing that antibiotics may or may not fix the issue. So when I'm telling them it's viral, and even though it's been going on and the secretions are green, but yes, it's still viral, people get angry. So we have to reinforce and stay strong with that. Sometimes when we've prescribed the antibiotics and we know that it was viral and they say they're better off or feeling better, oh, that really worked in a day or two, recognizing that it had probably resolved on its own. And I'll tell you, being in an urgent care setting, I was victim to a physician, and it wasn't a terrible thing, but he would prescribe. So you always had to worry about positive responses also. So sometimes I would do a delayed script, because literature does say that a delayed script, many people will not fill it. So when I got into that push situation, that's what I would do, but I encourage us to try to stay strong in situations where we can and not prescribe. So this presentation is going to talk about some of the evidence-based guidelines in regards to some specific pediatric disorders. But I'll spend just a couple minutes talking about pediatrics and adolescents. We recognize that the pediatric group, the young children, they're more susceptible to sickness. And we're thinking, why are they more susceptible? If you've had children, you'll recognize, okay, underdeveloped immune system. Or if you're taking care of them, recognizing that there's that high exposure to germs. But as I like to say, they go around and they lick everything too. So you got the toys, you got this, and then suddenly it's touching their eyes and touching their face. And so hand washing becomes really important. Items in their mouth as well as sharing. So after they're done licking it, they're giving it to Johnny, and Johnny's licking it and giving it to Joe. So it's just shared items. And you would think, as they went into adolescence, some of that changed, right? So I would tell all of my children, we don't share drinks right from infancy. We don't share drinks. We don't, do these things. And I go to visit my daughter in high school, and there she is sharing drinks with everybody. I'm like, okay, that really worked. So hanging out with friends, they're in close proximity, they're face-to-face. Even when they have their screens and they're sitting side by side with their computers or their phones, they're still there. Shared items, and then relationships, because now they're holding hands and they may be becoming intimate. So adolescence is hanging out and still reinforcing that hand washing too, because that's not happening many times. So some of the common disorders, not all that we'll talk about today, but common disorders in the pediatric population that you guys are seeing is that common cold, right? Pharyngitis, ear infections, conjunctivitis and croup. That acute bronchitis, because everybody who has that really feels like they need those antibiotics. But we'll also talk about the tridemic part with the influenza, the RSV, and the COVID. So, as we roll into it, recognize that these are all viral infections, right? So we're talking about viral infections that do not require antibiotics unless there's a secondary infection that occurs, and that does happen, and we'll talk about that a little bit too as we go along. So RSV, respiratory syncytial virus, we're finding that it impacts all ages. Now, what we've seen in the past is that, okay, RSV, not a big deal because it pretty much hits the kids. Most of them have had it, over 80% have had it by the age of 2, but we're concerned about the preemies. We're concerned about the ones with comorbidities, cardiac issues, acute chronic respiratory issues. And even though we're not talking about the older adult, we're talking about seeing an increase in RSV in elderly population groups. So recognizing that it impacts all ages, it's a respiratory disease and it's very contagious. So what are we doing with this? I want to recognize that the clinical manifestations, which means how is it impacting each age group, it varies. If the child is less than 1, we're going to treat them different. So the younger than 2 have a higher incidence of RSV. Preemies are at a higher risk with RSV. And then we look at pediatric patients, once I said, with that respiratory, the cardiac issues. Even if they're beyond the age of 2, we're going to be cautious as we're managing that patient. So how is it spread, right? These kids are pretty much sharing it, right? It's the nasal secretions, it's the mucous membranes, really reinforcing highly contagious. So we can reinforce good hand washing. Cough hygiene, teaching them how to cough. Avoiding smoke. One of the things that we noticed over the last few years until this year, which is why we're talking about this being a tridemic, is that RSV was almost invisible. During the peak times during COVID, we didn't see much RSV. We didn't see much influenza. Does anyone know why? We're all wearing masks, right? And then otherwise they were isolated, right? So isolation for part of it, but also wearing masks. Once we went back into the community, they were wearing masks. So ways that we can prevent it, we can't prevent childcare, right? They need to go to school. We realize that's important. So really reinforcing good hand washing. Now, when we look at the palivireximab, and I'm going to call it Synagis, that was my one time that I had to say it for you, so I'm going to refer to it as Synagis. Synagis is a medication that we're prescribing to targeted groups. When we're looking at BPD, bronchopulmonary dysplasia, those infants with BPD, when we look at providing or pre-medicating or, vaccinate, there's not a vaccine. When we're prophylactically treating them with this Synagis, it's at the child that's less than 1 year of age. It's at the start of the RSV season, which is November. It's 5 doses of the medication. That medication is given monthly. Now, we want that medication to be given less than 35 days. Because if we give it monthly, 5 doses, less than 35 days, then we're going to decrease that risk of hospitalization and decrease that risk of severe disorder or severe disease symptoms. I'm going to go back once more to that, I think. Yes. Now, when you look at the second part of that second sentence, we're looking at children 12 to 23 months. When we look at that group, we're still talking about that BPD group, but those are the ones that started in November and didn't have any respiratory or cardiac or medication complications. If they started having some complications during that peak RSV season, then we would go ahead and start the medication, the Synagis. Now, the thing about Synagis is that it's expensive, and you're talking about 5 doses. So when we're looking at this group, we've decided that prophylaxis treatment is better than not treating, especially when we're looking at 12 to 23 months, because primarily we're treating that up to 1 year of age. So this one talks a little bit more about the target groups that we're looking at. Infants younger than 1 year of age, with cardiac conditions or neuromuscular disorders or pulmonary abnormalities, tying into what I was talking about. When we're looking at that synergist, basically it has been prescribed for the prevention of the serious RSV, that respiratory tract disorder. There's an increased associated morbidity in this population group if they're not treated. Children younger than 2 years of age who are immunocompromised is also a target group. We're also looking at the Down syndrome, right? Because we talked about the cardiac problems in this population. The Native American and Alaskan Native infants are also high risk. So I talked about this medication. I talked about it being a prophylaxis treatment. I talked about us really targeting those preemies and starting it in November. It is an IM injection, right? So this time, this year, with the COVID, with the influenza, we saw the RSV season start early. We recognize that giving this injection does not interfere with the regular immunizations. So we can give these injections and still appropriately immunize the child. But with this starting early, the American Academy of Nurse Practitioners, the American Academy of Pediatrics gave us permission to potentially start the treatments earlier, since the flu season in different areas of the United States started earlier. We also had permission to extend it beyond that period of time because the flu season may extend. So working from two angles, 1 dose or 5 doses once a month can be extended based on that risk factor with that population group. So what do you think happens to a 5-year-old with RSV? What are their symptoms like? It's a cold, right? So you're seeing the difference in what we're talking about in regards to the severity of treating prophylactically this population group. Reinforcing administration is 15 milligrams per kilogram. It's IM once a month, max of 5 doses. And then I already talked about the exceptions, right? We're looking at an exception if the season starts early. We're looking at an exception of extending it. We're also looking at what happens if they age out, so 1 year of age while they're in the middle of it. We would continue it if it's still within the season. So if we're in RSV season, they became 1 in December, we would still continue that treatment for that preemie that doesn't have those significant comorbidities that I talked about. So just reinforcing, first dose before the season begins, interval not exceeding 35 days. If it's initiated at the beginning of the season, all 5 doses are going to be administered. Now, thing I didn't mention is if they have a breakthrough infection, then we would go ahead and stop the treatment. And that's based on efficacy. We talked about the increased interseasonal RSV activity. So what are we going to do with that? What does that mean? It means that we're seeing RSV in the off times. As I said, we saw it before the season started, and in 21, we saw it beyond the season ending. So that showed or reflected an increased hospitalization and hospital visits. Part of what we reflected on when we looked at that population group is, was it an increase or was this increase because there was the suppression by COVID? So did it, rear its ugly head and become more severe because no one had experienced it, or had the immunity decreased? So reinforcing why we are aggressively going outside of the guidelines of treating this patient. There's not an RSV vaccine, because you're thinking, oh, well, why don't we just have an RSV vaccine, right? We can eliminate this problem. Well, part of it is because the pediatric group that we're working with is less than 1 year of age. We're talking about subgroups of RSV, so we don't have the opportunity to really build that vaccination. The immature immunity of that preemie, or the one who's less than 2 with the comorbidities. Suppression of the immune response by the maternal antibodies, and then was that a question? No? Okay, sorry. Genetically divergent strains, and once again, that's just the strains changing, growing, becoming different. As we know, as time changes, this strain is becoming more resistant to the treatment. So that's been a challenge to developing a treatment or a vaccine for RSV. So big thing we saw as we talked about this tridemic is increased incidence of RSV as well as influenza as well as COVID. I am not talking about them having them all at the same time. They can be back to back to back, right? Because they're viral infections. Someone who's had RSV who's now exposed to COVID is going to have an increased risk of hospitalization. Once again, reinforcing who's at risk with that RSV as I tie it all together, that preemie. So we want to avoid that high hospitalization rate. One of the things we saw at the beginning of the season this year, hospitals were full. Doctors' offices were full. Urgent cares were full. So we're trying to look at prevention. And that takes us to the next topic as we're looking at the influenza, right? So with the influenza, guys, one of the best things we can do is look at prevention. And how can we prevent it? It's through the flu vaccine. So influenza usually is an acute respiratory illness. The biggest incidence we see is influenza A. We recognize the information in regards to influenza. It's usually self-limiting, so we are basically going to be supportive of that patient. And it's uncomplicated in the healthy child most times. Flu really made an impact this year. So a lot of really sick people, but it was mostly the people who had not been vaccinated. So really reinforcing, I know people are suspicious of vaccines, reinforcing vaccination, recognizing that the presentation of influenza varies. So as we go into that, transmission, we already talked about those kids, right? Those ones that are licking everything, touching everything. They're the ones who are helping to transmit the flu. So we're also looking at the, go back one. It's a little sensitive. Incubation period. So when we look at the different flus, and that'll take me to the next one, influenza A and influenza B, the incubation period is a little bit different. The person starts shedding the virus. They're contagious with influenza A pretty much 24 to 48 hours as they start becoming symptomatic. With influenza B, they're going to have that shedding before they become symptomatic, so they're already sharing it with you before you come in contact with them. And then they can shed it again afterwards. So minimal detectable virus replication in A after 5 to 10 days, but recognizing that this season, we saw influenza A really take hold and stay. People were feeling symptomatic for over 2 weeks. So the burden of disease ties into what I initially talked about. Remember I talked about the outpatient, increased hospitalizations. We talked about mortality, increased risk, and who's at risk for mortality, and we'll talk about that in the next few slides. The rate of visits among children vary each year. We saw 6 to 29 per 100. This year we saw significant increase. Hospitals were full. Greatest rate, infants under the age of 6 months. Why? Because they are not getting vaccinated, right? Or someone's bringing it home. The rate is greater in the high-risk children. And then tying it together with the mortality. We can see co-infections. They can present with that strep pneumonia, strep aureus. We talked about not using antibiotics in these cases. Antibiotics may be indicated, recognizing that it's important. We've also seen an increased influence or circulation of the swine flu, recognizing that it's not significantly high, but it is out there also. So with the uncomplicated influenza, we're going to be looking at some of the classic symptoms, but those symptoms, how are we going to manage these symptoms? Are we ready to start antibiotics because the parent came in and said, oh, they have a runny nose, they've had a fever for 5 days, and what are we going to do? They need to go to school. I need to go to work. What's our answer? Sorry, right? Unless you work in an urgent care. No, I'm just kidding. So yeah, we're going to stick with it because we know that there is an increased resistance to antibiotics if we expose them prematurely. So I know you guys know a lot of this information, but as we tie it together and recognize the impact that it's having right now in the community, reinforcing how important it is to review it again. So the uncomplicated influenza, this patient may look a little different. They may not have the classic features. They may show up with the higher fevers. Having febrile seizures does not change how we're going to treat this patient. They may present with the GI complications. We are going to stick with the supportive care, hydration, acetaminophen to keep the fever down, answering any questions with the parents, making sure they're looking for signs of dehydration. That's where education is going to be very important on our part. And then when we're looking at the management, right? So acute, self-limiting, we talked about it, more severe illness may occur, but they're going to start getting better. We have to work with the parent. Stated that it's stuck around for a couple weeks. You're going to see with influenza, they may have an increased risk of an ear infection afterwards that we may manage. Maybe they're reinfected with a different type of influenza. How many of them have had influenza A and now presenting with influenza B? And then recognizing that the vaccine is important, even if it's later in the season. So some of the complications they may present with, because what we saw, as we looked at all of this in recovery, we saw an increase in severity of the hospitalizations. And you'll hear me say that over and over again, because that's going to help us prepare for the next season. The complications, we see the ear infections, the pneumonias, the respiratory complications, secondary bacterial infections, the fungal infections, musculoskeletal and cardiac conditions that may present. But let's talk about some of the lab testing, because another thing that there was a deficit on, according to literature and in some of my areas, were just some of the basic supplies to be able to swab someone. So we're going to basically test them appropriately. It's performed when the results affect the decision making. So if we think we're not going to do anything different, then we may not need to test that child. If there's not a supply of swabs, we may have to use them for something else. So keeping that in the back of your mind. The decision to test, depending on the availability of the test and results. This is not going to delay our treatment. If we think it's influenza, if we can test them, we are not going to delay our treatment, because we know with our treatment, the best treatment is starting within a few days of the symptoms onset. We're looking at molecular assays and the antigen detection test for actual lab tests that we're doing. Reinforcing treatment, and then I'll go on to the prophylactic treatment, or treatment once we've decided that they have influenza. We got to manage the symptoms. It's like I had an adult come in once with an ear infection, and he was crying louder than the child. So recognizing that pain is something we often forget. We sometimes think that people know to treat with ibuprofen or acetaminophen, recognizing that we're not going to treat with aspirin, right? Over-the-counter cold medicines have been proven to be not effective. Sometimes not proven to be. There's no obvious benefit, because it hasn't been proven to be, because we know that some cases it has been effective for some people. But it's not recommended. There's no proven or identified benefit to it. And then the other part, guys, we got to look at how do we prevent the spread. We educate people on keeping the kids out of school until the fever resolves, because as long as their fever is in place, they potentially are considered infectious. And I know that's like common knowledge, but really reinforcing it as a person who was a school nurse for over 15 years. And I thought about giving my kid acetaminophen and sending them to school, but a lot of parents really do that. So really reinforce not, because obviously the acetaminophen will wear off and then they're still being sent home, but at the end of the day, they're still contagious. So recognizing that 24 hours after the fever resolves is when we'd start sending them back. So looking at our neuroamidase inhibitors. Yes, that's where we are. Am I missing one? No, I am. Okay. Challenging myself with my finger, so thank you guys for hanging with me. Looking at our antiviral treatment, guys, neuroamidase inhibitors, it's basically preventing the release from the host cells. It's active against influenza A and B. And then we look at some of the different medications and recognize these are not always the common ones. I brought some out just so that we can think about it. And then I'll get to the common ones also. Baloxavir, basically, It's administered as a single dose, so we're thinking, oh, that's easy, we can utilize that. But it blocks influenza and protection, but it's not the one that we commonly use, and I'll tell you why in just a little bit. This adamantium, it is not active against the influenza B, and it's not even used within the United States. And you're like, why are you mentioning that? Because we want to be knowledgeable about what's going on and what's out there. So there's different types of treatments. And then we look at recognizing that the earlier treatment, the earlier we start the treatment, we know that typically we have 48 hours, 72 hours, even though we're starting treatments beyond that recommended amount of time, but the earlier the treatment, the better the outcomes. This inhibitor, once again, can be administered more than 48 hours because initially we learned that 2 days after it's not going to be effective, so we're not utilizing it. It can be utilized. And overall, it's shortening the duration of the symptoms. But even beyond that, what it's doing is it's helping to not spread it with other people. So we're preventing the spread of it also if we're following the guidelines appropriate for that. I definitely feel like I missed one of the slides. So I'm going to tell you a little bit of information that I wanted to say just in case I jumped over the slides. When I talked about the Paxlovid, okay, I got you. You guys are hanging tight with me, and I appreciate it. Thank you. I just kind of. Okay. Okay. So one of the things I wanted to talk about are some of the preferred treatments. I have a habit of going off task, so I keep my notes with me because you don't want me talking without my notes. I like to talk, but I want to talk to you about the oral oseltamivir, which is the one that we use. This is the Tamiflu. When we're looking at it, it is the one that's most recommended for children under the age of 5. When we're giving the medication, recognizing and reinforcing that it is safe for administration, but we may have some GI complications associated with it. When we're looking at children older than 5, the one that I mentioned before, the oral baloxavir, the one reason why we're not utilizing it as common because it's not recommended under the age of 5. So the oral oseltamivir, the Tamiflu is what I'll reference it as, is the one that's most commonly used. How many of you guys have seen a lot of flu in your community? Hands? How are you treating your patients? Same? Now, before when we were treating, we were concerned about the patients or the parents and explaining to them that, once again, why are we utilizing the treatment? It's going to resolve. We said it's a virus. Is it really helping? Reinforcing that once again, it's decreasing the days of exposure, decreasing the community exposure, but also recognizing that it is something that is going to help decrease the spread of it. So it is basically we're giving the oral oseltamivir in the outpatient setting. It's the patient that's not severe, and basically we're using it in a confirmed or suspected case. And that's what I wanted to reinforce. Remember how before we didn't start it unless it was confirmed. But now we're going back to saying having supplies might be a factor. So if we don't have supplies and we're suspecting this influenza, we are going to already go ahead and start that treatment. Now, if it's greater than 5 years of age, reinforcing the outpatient setting, we're using the oral oseltamivir, the Tamiflu again, and once again, the choice is determined by age. With this severe illness, we're still doing that. Now, when are we looking at the IV medication? We're looking at the IV medication when they are not able to take the oral medication. So our primary go-to medication, as you guys have seen, is the Tamiflu. Administration 5 days. We're going to treat the caregivers because we're going to try to prevent the spread, especially as there are other people in the house to prevent that co-infection. And then we may need extended treatment. So before we stuck with that 5 days of treatment, we're now saying if they are continuing to be symptomatic, severely ill, not just the basic symptoms, we may extend that treatment. The dosing, if they're under the age of 1, it can be age-related or based or weight-based, and this is what you see in here. So if we don't know the weight, we can dose by age, breaking it down to what you see. Now, when we're looking at the zanamivir, that's one, like I said, I want to go through some of the different medications because I feel like they're good to be able to talk about. So when we're looking at this one, it should be avoided in children with a history of wheezing or any underlying health conditions. So you're thinking, okay, this was one that's a good potential one that we can use. We can use it in children over the age of 7. We have to recognize if they have any or respiratory issues, history of wheezing, any history of asthma, this is not the patient we would use it on. This is through inhalation. It's like a disc. It's 2 inhalations twice a day and a 5-day administration. Prior to pulling all of this together, I was like, oh, Tamiflu, Tamiflu, Tamiflu. So I really enjoyed getting the details related to the different options that we had. In my pediatric setting, I'm pretty much sticking with the recommended guidelines, the gold standard, which is the Tamiflu. Peramivir is the one that I talked about where there's an IV administration, recognizing that many times we're using this in that patient who cannot tolerate the oral medication, the oral Tamiflu. Dosing varies from 6 months to 12 years of age, and then we're going to look at, once again, are they in the hospital as they're getting this treatment? So this is typically the severe patient that's getting this one. And then tying into it any comorbidities, basically any suspected bacterial infection. So it's going to be determined or guided by our examination in our specimen culture if we actually get it. We are used to seeing potentially a pneumonia with the patients, but also looking at, once again, otitis from what we've seen in our setting. We're going to treat them aggressively if there's a pneumonia associated with this patient. We're looking at that broad empiric therapy, and then we're looking at aggressive treatment with Vanco plus the second antibiotic plus an antiviral agent as needed based on that patient's presentation with that life-threatening pneumonia. It's not with any of the other secondary co-infections. We typically just go with a broad spectrum antibiotic with some of the other co-infections. So when we're looking, I'm going to just touch bases on, before I go away from that, I want to just touch bases on that lower respiratory tract infection. Some of the co-infections that we see are specifically strep and staph, right? So that is what's going to put them at a high-risk condition. That can be actually severe and potentially fatal. So that's why we are treating it so aggressively. Yes? No. If we're talking about a severe pneumonia, absolutely. If we're concerned that's one that's going to be hospitalized. She had a great question and differentiated between what's the setting for that. So if we're talking about a life-threatening pneumonia that's not outpatient, that's not urgent care, that's hospitalization. We would not do that in our office, as she appropriately said, and thank you for that differentiation. We would be recommending this person to be hospitalized and treated appropriately. That's a severe when we're at risk for death there. Did that answer reaffirm? Thank you. What about anyone else? All right, I like interaction. I like questions, so please continue. So for children with life-threatening pneumonia, complicating that influenza, reinforcing, like we just talked about, that Vanco, that second antibiotic, plus that antiviral. And some of the things that we forget is to continue with that antiviral. And now we get to COVID. You guys are experts on COVID, right? There is basically just some information I want to reinforce. Can you have COVID and a secondary infection? Yes, we've all seen it, right? How do we treat it? Do we treat both infections or we just treat one? We treat our secondary infection based on appropriateness. So with the viral, or COVID, it's a severe acute respiratory disorder. It was identified in 2019, COVID-19 virus. We had over 55 million cases and over 825,000 deaths. We know that's just a loose number. I got that from, as you see, McGowan in 2023, the citation. We know that there's different reporting mechanisms, so that's not always the most up-to-date information. What I want to reinforce is children of all ages can get COVID. The key thing that's going on now is they're not dying from COVID. Or they are dying, but they died from COVID, but not in high numbers. Let's reaffirm that. So, yes, can children die of COVID? Yes, children are still dying from COVID, but it's not significantly high numbers because we are treating. We're not going to get into the politics of mask, don't mask, treat, don't treat, immunize, or vaccinate, don't vaccinate. But we just want to recognize that children do get COVID. Over 16 million lab-confirmed cases, less than 18 reported to the Center for Disease Control. Now, we want to know, is COVID still around? Everybody's walking around saying COVID's gone, right? No, COVID's not gone, but the severity of the disease is less for those who've been immunized. We're not seeing as many co-infections for some of those patients. I'll share my short story because my mom decided, she's 75 years old. She wants to see everybody. So over Christmas, we all got together in Davenport, all 34 of us. So it was a lovely event. We were there for 7 days. What do you think happened after that? So yes, out of the 34 people, 6 had COVID. And 1, 2, 3, 4, 5 of them had not had COVID before. My mother, my brother who's immunocompromised, my other brother who's immunocompromised, my son, and my nephew, maybe 7, one other nephew. So that's pretty good to reinforce that COVID is there, but we also have to let people know it's okay to live. We saw that the psychological impact on the pediatric patient with COVID has been severe. We saw that the education, the students not getting the education or getting education that's not to the full extent is lacking. The interactions with their peers are needed. So even though COVID is still there and we're educating people on good hand washing and really reinforcing that if they're sick, it's a good time to not be here, it's important to have that interaction. With my family, everybody was okay. I'm a driver. Anybody who's met me, I'm a driver. So I drove from Florida to Maryland to help my brother because he's not a good listener. He's very intelligent, one of those people with the high IQ all the way up there, but doesn't get it. And we're having a FaceTime visit. We meet on Sundays with my mom, and I'm like, why do you look terrible? She's like, fighting me, like most people do, saying, I've taken 5 tests, I'm fine. And I drive from Maryland past my house to go to her house, and she's positive. But everybody recovered well, and I'm going to say that that event was worth it because we have to get back to some normalcy for the mental health aspect of a population group. So COVID is evolving. The World Health Organization, the CDC, the American Academy of Pediatrics, and other expert groups are reinforcing some of the information that I just said, the importance of peers being with each other, having that communication, finding a level of normalcy, and continuing to get that higher education that's needed. So with it, we know that it's highly infectious. We know that it's transmitted via respiratory droplets, respiratory secretions, saliva, aerosols. Hand washing works, hand washing. We know that masks do help in regards to the spread. We're making a conscious decision, I feel, when we decide not to wear masks because it's okay. It remains on surfaces. It's viable on surfaces for hours to days, reinforcing hand washing, cleaning the surfaces. And then it's found with fecal shedding. So initially, most of the cases were in-home exposures, if you guys remember, because most people were in the home. And then we said they need to go back to the school, and they did. As a nurse and a nurse practitioner in the school district, the kids needed to go back. So then we saw the healthcare associated outbreaks and transmission in the school environment. So I'm a strong believer that the kids really did need to get back to that environment. We still need to educate, though. Now as we're looking at hospitalizations, recognizing that the rates varied. The rates peaked in January of 2021, September 2021 with a different strain, right? Got the Delta. January 2022, the Omicron variant. That was less intensive, very much more contagious though, spread like wildfire within a room. Recognizing that the shedding from person to person varies, and children of all ages can transmit. So as we go back to our vulnerable population, who do we think is most vulnerable for these high risks, or who's going to be most vulnerable to having poor outcomes, health outcomes? Young, right? But also, we may see it when we look at some of the social determinants of health, and I'm going to go there just for a moment. We saw some of the poor outcomes in persons with lower literacy levels. We saw some of the worst outcomes in persons living in crowded living conditions. Did we see an equal access of distribution to Paxlovid or whatever the treatment was at that time for patients who were immediately exposed? So we have to make sure that everyone has equal access to services, and that becomes a key part to our job as we're looking at these, because COVID's going to stay, right? We think it's like the flu. It's not going anywhere. We're going to have a new variant. Don't quote me on that, because if it goes anywhere, I will be happy to say I was wrong. We would love to say it's gone. But we have to move forward now knowing that it's not as severe potentially. We have immunizations or vaccinations in place. How do we get back to some normalcy? We want to recognize that there is no mother-to-fetus transmission. So mom is not transmitting it in utero or as she's delivering. It's not transmitted via breast milk at this point also. Family clusters, a mode of transmission. Raise my hand. Nice family cluster. It was actually a test is what it did. I'm going to do a write-up on that one. And then fewer cases diagnosed than adults. So the majority, when we see the cases, the majority are mild. The majority are people who are not vaccinated. And we recognize that vaccines are a choice. So back to our risk factors. The persons with underlying health conditions have higher risk. The diabetes, the sickle cell, the medical conditions, and genetic conditions. So if we are recommending vaccinations, we're going to highly target the ones that have a greater risk for severe disease, but also recognizing our patients have a choice. So if they're not going to vaccine, at least reinforce good hand washing. Potentially, if they're out in an area that's crowded, wear a mask. And I am a supporter of choice. My one brother who caught it has chosen not to, but he wears a mask everywhere he goes. So how do we protect our patients? So reinforcing to them, you have a choice. Okay. Try to take care of yourself, protect yourself. We can do that with our high-risk children and our high-risk infants also. Once again, underlying health conditions, reinforcing the neurological conditions, immunosuppression, vaccination status, and common underlying health conditions. Those are some of the key risks for severe disease, especially our immunocompromised. Now, do you think we'll be able to take advantage of the opportunity and educate under some of the other conditions, like kids with obesity, kids with diabetes? Can we take advantage of this opportunity and bring that into our education? What do you guys think? Anybody? So we can decrease some of the risk with the education. But as we look at that, and once again, I have you guys captive audiences, so I'm going to reinforce it. We remember that the parents are the ones feeding the child. So if we're going to talk about obesity and decreasing the risk, diabetes and decreasing the risk, asthma and decreasing the risk, we have to include that parent in the conversation. They're the ones cooking the meals. They may be the ones smoking in the house. They may be the ones not recognizing the high risk for diabetes based on the obesity. So really, family education is going to be key. So just kind of tying together what I said in the beginning, deaths remain rare in children and adolescents, but they do happen. If it's someone's child, that's still a death. So we want to educate. I talked a bit on racial and ethnic disparities because African American groups, Hispanic groups, lower socioeconomic groups, economic groups had a higher number of cases of COVID-19, higher hospitalizations and deaths. And then once again, is that because of the SDOH, the social determinants of health, the healthcare disparities? Did they get the same treatment once they were hospitalized? Okay. And then once again, reinforcing that fewer cases. Cases are mild. Now, I throw a differential diagnosis in here just because if you happen to live in Florida and you have a presentation that said differential diagnosis, that counts towards getting autonomous practice. So most of my PowerPoints will have some differential diagnosis because as we work to strive towards that, we need it. So as we're looking at our patients, looking at what potentially is going on, adenovirus, the pneumonia, the influenza, RSV, a lot of these symptoms are the same now. COVID isn't the same, right? We first started with COVID as, you're presenting with high fever, now we're presenting with potentially headaches. You're not losing taste and smell. So as it's evolved, as we've had different variants, the symptoms are now different. Some of them are similar to the influenza and RSV. How many of you guys have the test in your clinic that you can test for multiple things at one time? That's great. Mine's not so much, but that is great because that's going to help. Have you had any problems with supplies? No? Everybody's been pretty good? A couple nods. So just reinforcing that that is what's going on in the community. So looking at our diagnostics, the PCR, the antigen testing, we're also going to rule out the influenza and the RSV because we could have some comorbid or co-infections, and rhinovirus and imaging studies. Those are not all things we're going to do. Those are things we're going to consider. So don't hold me to, why are we doing a chest x-ray? We don't have to unless we're concerned about a pneumonia or something else going on, right? Now, virus, supportive care. We're going to look at isolation. No, we're not isolating anymore. We're just separating. We're not going to school. We're not sharing with anybody. We're going to give them respiratory support. We want to make sure they stay hydrated. We want to monitor for any long-term effects, which is what we'll talk about at the next slide. And then we're going to look at antivirals. And the antivirals are going to be based on case by case. So when we're looking at mild or moderate disease, guys, they don't need anything. They don't need supplemental oxygen. Then that's the one that we're like, okay, may just watch and wait. That's our supportive care. We may also look at, treatment. What's some of the treatment that we'd look at? Remdesivir, right? But let's go back. We would not necessarily utilize that if they don't qualify. So mild to moderate, only if we think that they're at risk. Severe, we're looking at potential hospitalization now because they need oxygen. How many of us have oxygen at home? No, we don't. So severe disease is looking at hospitalization. And then we're looking at the critical disease aspect. Those are the ones that are potentially on some support with breathing, the invasive mechanical ventilation. They may have sepsis, multiple organ failure. But our goal is to not get to that point. We also said that the majority of the cases are mild. So the antiviral therapy, that's basically the remdesivir that we've been utilizing, but going back into patient presentation and who qualifies based on what symptoms they're presenting with, comorbidities they have. Now, I like this slide just to make us all think for a minute because up until this arena, up until 3 years ago, my go-to as a healthcare provider was the World Health Organization and the CDC. So I think there's a little bit of work to be done there. The COVID is evolving. These guys are still the ones providing us with the information. We have to build a trust again, right? Because they learned, as we did with COVID, as it was going along, recognizing that some of the recommendations and guidance that they gave us changed overnight. So things like, how many of you guys have worked in a hospital setting and you had to wear an N95 before going into any room that's contagious to, no, you can just wear a mask, right? So now we have to rebuild that trust in the World Health Organization and the CDC. And I think that the trust is needed. We need to have that governing body. We talked about COVID and the impact it's had on the incidence and prevalence of other common disorders. That was where I brought in the RSV. That's where I brought in the influenza, because they were pretty much suppressed for the last few years until end of the year last year, and suddenly it was raging. We talked about why. Partially because we wore masks and we weren't around people. Then why was it so bad? It's had time to gather strength, to become more resistant, and make a more significant impact. How can we help with that? Treating early, providing vaccinations as needed. Okay, and then with the assessment. So I want to go into the multi-system inflammatory syndrome, recognizing some long-term effects of children who had COVID. And what is that? We thought initially that it was Kawasaki's disease. Remember, we're like, oh, these kids are getting Kawasaki's disease, and Kawasaki's disease doesn't happen like that. Kawasaki's disease is also a multi-system inflammatory disorder or syndrome. So what we saw is a delayed response to the virus. These kids presented with fevers, long-term cardiac problems, scary neurocognitive symptoms, long hospitalizations, and then we looked at the swollen hands and feet and severe stomach pain. So initially, we did not know how to treat these children, and there's still no significant change in how we're treating them. This happened, it was rare. It happened in less than 2% of the children. We had to differentiate it, like I said, from Kawasaki's disease, and then recognize that it's overall just an abnormal immune response to the COVID virus. So most of these kids were hospitalized. They were given IVIG, glucocorticoids, and they were observed. Initially, we didn't know, obviously, what it was. Now we are able to treat them unless they're severe in outpatient management, observation, and then just see. I mean, a lot of this, and I wish I could say, oh, we know exactly what's going to go. We don't know what's going to happen in the next few years. We don't even know the response we're going to see to some of the vaccines that we've had. So with that patient that presented, as we were doing some lab work, we saw some abnormal blood count, elevated inflammatory markers, cardiac markers, hypoalbuminemia, yes, that too, and some elevated liver enzymes, and that was mild. We also saw that hypertriglycemia, so that too. Okay. Next time, I will catch it all. That was scary, though, guys. I want to go back and tie that up and not just have it, stuck on me with a word. That was really scary because we really did not know what was going on with that population group. We are managing it, like I said, for the persons that are hospitalized with IVIG, but we don't know what the long-term problems are going to be for that child. So at the end of the day, we are anticipating some potential problems with this population group, just as we saw with RSV and influenza, from COVID that we haven't seen yet. Do you guys know what I mean? It's like, overall, the disorders that we've seen in the past are potentially going to change based on what we don't know yet. So keeping your mind open, recognizing that you need to stay up to date with literature, finding reliable sources as you stay up to date with literature is going to be important. All right, so let's take it to some easy stuff. In the past, RSV, influenza, and COVID has been easy, but now that things are presenting differently, it's important that we know some of the details about it. So let's talk about our acute otitis media. Now, we're seeing that because it's a secondary infection from typically the influenza or even from the RSV, because in the older age group, RSV is just a cold. So these kids are presenting with that inflammation of that ear. Common in the age under 5. We see it in older kids, obviously. Peak incidence, 3 to 18 months. We're seeing it in the kids in school. We're seeing it in the ones who recently had a cold. Strep pneumonia is the most common agent in kids. And H. influenza, boom, 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 back to that flu, as well as Moxarella catarrhalis. So, what are you going to do? Does everybody with an ear infection get antibiotics? My area didn't have amoxicillin for a minute. I don't know about your area. So it makes us stop and think. It's like, okay. So we know that we're going to look at the signs and symptoms, and it varies with age. Neonates, in regards to treatment for influenza, based on the presentation, if they don't have, neonates based on the fever, and I'll talk about it in a couple slides, we will end up treating them, and you'll see that. But they are presenting with irritability because they're not going to be able to tell you my ear hurts. It's our assessment. Mom's going to come in and say, oh, they're tugging on their ear looks red or something going on, because not the inner ear, because you can't see that. But if they're tugging on that ear, they may have a red external ear just from the touch. The older children, now they know, right? You can fever, you're talking about some pain, and they're pulling on their ear. They may have hearing loss. Those are some of the common symptoms. Now, when you take a look in that ear, recognizing that if they're crying when an assessment, we all know this, that ear is going to be red, unless you don't play with kids a lot. In the pediatric population, as soon as you come with that otoscope, they start crying. That red ear is not an indication of an otitis media, okay? It's an indication that they don't want to be bothered. They want their mom. Some of the common risk factors: low birth rate and prematurity, age. If they start having ear infections early, then they're going to have a higher risk for continued ear infections. The family history is a factor, race, as well as immunity. We're going to look at the kids with any type of craniofacial abnormalities. Obviously, that's going to affect that ear and potentially increase their risk for infection. Neuromuscular disease, and then hearing loss. So all of those are some of the common risk factors. As we looked at the assessment, once again, what did they present with? You got your detailed patient history. Now you're going to look at the assessment. That pneumatic otoscope is going to be key if you have it. Otherwise, I don't have a pneumatic otoscope. I have an otoscope. So even though that's the gold standard, recognizing that many of us don't have that in our clinical setting, it's okay. It's a standard of care and a diagnosis, but we're also going to use that history, that presentation, and decide whether or not we're going to treat that patient. Diagnosis is confirmed by changes in the tympanic membrane, but remember what I said, just being just being red is not enough. Is it inflamed? Looking at the contour. Are you seeing it mobile when you're using that the otoscope? So mobility, how is that? And are they experiencing any hearing loss? Differential diagnosis, why are we talking about differentials? Because it works. It's also part of our assessment. We have to rule out, is it an externa? Are they having any dental pain? What about TMJ pain? Could just be viral pharyngitis or trauma to the ear. Could be something in the ear. Some of my favorite findings is looking in the ear and seeing, we live in Florida, right? How many of you guys have looked in an ear and seen a surprise? Oh, there is a bug in your ear. A pleasant surprise, not unpleasant. One of the patients I had was in school that day, and no one could come get her, so she spent the day at school with a bug in her ear. And in the school environment, as a nurse practitioner, we didn't remove bugs from ears, even though you're thinking, why didn't you just remove it, right? We didn't do that. So there could be trauma to the ears. So we're looking at to treat or not to treat. Recognizing that sometimes the symptoms resolve within the first couple days. It may clear up on its own. And this is what I was talking about in regards to who are we going to treat. The American Academy of Pediatrics basically said we can take that wait and see approach if there's not a fever in that population group, when we're looking at 6 to 24 months. If there's only mild pain, how many parents do you have that want to wait and watch and wait? Not many, right? And some of the things I learned to realize in myself in an urgent care setting, and I learned that the hard way, when that parent came back in 2 days, they had to pay again. I didn't realize that for my first 3 months as a nurse practitioner, as I told people, come back in a couple days. And then they came back and they had to pay. So keeping that in mind, it's not a choice. If they are using any type of insurance, it's illegal to not, at least in Florida, they have to pay the copay when they come back. So keeping that in mind when you're talking about do you prescribe or do you not prescribe, do you give a script and say if it doesn't improve, start it, those are all considerations. Children 24 months older with a middle ear infection, ear pain in one or both ears for less than 48 hours and temp less than 102. Key factor is temp less than 102. So we're going to look at management. I already talked about pain. Pain is important, so we got to make sure we do the acetaminophen or the ibuprofen based on the age, recognizing ibuprofen is not prescribed in individuals or patients less than 6 months of age. And then use care when recommending over-the-counter meds, because remember in a couple slides ago, I said it's really not effective as we're talking about the cough or the nasal congestion that may go with that. Also, if we are telling them to use acetaminophen, we have to recognize that a lot of those cold and cough medications, and I know you guys know all of this, it's just so that when you have students, you can reinforce that information, bringing it back to the front of your brain, that that medication may have acetaminophen in it. So now we're double dosing. So keeping that in mind as you're prescribing it, but literature says that that medication is not even effective overall. It's not making a difference. So our first line of treatment is penicillin. Whenever I would prescribe that as a new nurse practitioner many, many years ago, I always felt uncomfortable because it's such a high dose. But recognize that the reason it's a high dose is to prevent resistance. And how often do we give penicillin? We're usually doing amoxicillin because of the taste factor, right? Now, if that patient presents with any allergies to penicillin, now we're going to look at the cephalosporin. But we've heard that there's some cross-reactivity if we go with cephalosporins if they have an allergic to penicillin, an allergy to penicillin. So we want to know what their allergy was. If it was something mild, then we can comfortably prescribe that cephalosporin. And then for the patient who cannot handle the medication, then we're going to be looking at the ceftriaxone or that Rocephin injection, and then following up to see if that's it, that may be all they need. How many times do you guys have parents who say, I can't get them to take the medicine? Right? We're like, those are ones where we don't get to do what we learned many years ago. It's like, you just blow in their face, they'll take everything. We don't get to say that anymore. But we don't tell them to pinch the nose. We want the experience to not be traumatic. So reinforcing ways, go away from some of the old school methods and not make this medicine a traumatic event because it's going to impact how they take medicine in the future. Another alternative is the macrolides. We have to be comfortable with the different alternatives because we have seen shortages, like I said, in my area. Even if it was just for a couple days, there was a shortage of amoxicillin. I remember being a new nurse practitioner and there was a shortage of Bactrim, and I'm like, what am I supposed to give my kids with UTIs? That was before we started using the macrobid more so. So recognizing what your alternative treatment plans are. So treatment, 10 days for children under the age of 2 or 2 years of age. If they don't have any previous history of AOM, then we can look at 5 to 7 days. If they've had a history, a couple slides ago we talked about resistance, so harder to treat. So that reinforces the importance for sticking with those 10 days and explaining to the parents how important it is to complete the medication. And then if we just incidentally find it, we can just watch and wait, especially if that patient is asymptomatic. If they're older than 2 years of age, there is no fever, we can follow up with a phone call. Have them tell us how the patient's doing instead of treating it. Reinforcing resistance is more common in the children who've been treated within the last 30 days, under the age of 2, and attending daycare. And attending daycare, in the past, we're like, that's how we build up. You wonder the first couple years when they go into daycare, why are they so sick? It's because they're starting to build that immunity. They have that new exposure. So we're expecting to see an increase in the otitis media in that population group. Now the serous otitis media, because you fixed them with that AOM, but now they're still presenting with some fullness in their ear. They're still having some discomfort. There's no signs and symptoms of ear infection. So do we treat them again saying it still must be an acute otitis media, we just didn't finish it? No, right? We're recognizing that it could be serous otitis media, where we have that fluid building up behind the tympanic membrane. So that is going to be a person who's asymptomatic from the other things that we talked about, the pain in the ear, the redness in the ear. But if you look at it, you might see some bubbles behind that tympanic membrane. You might see the fluid level behind the tympanic membrane. They're presenting with some popping or fullness in their ear and then feeling dizzy because there's a fluid going on. That eustachian tube is not appropriately draining. So this we have to watch. It can resolve in 3 months, but we also don't want it to impact hearing. So if they have it for more than 3 months, it can impact hearing loss. If it's full enough, it can rupture. So we don't just say, oh, come back in 3 months and we'll look at it. We have to follow up with that patient and monitor appropriately. And then our acute bronchitis. I like to mention the bronchiolitis. If I didn't mention it in RSV, and I think I have another slide here, so I'm getting ahead of myself. That's why I try to stick to the script. But with the bronchiolitis, RSV is 70% of the cases coming from that bronchiolitis. So with acute bronchitis, we're seeing that inflammation of the trachea, the bronchi, and the bronchioles. We're seeing an association with a viral syndrome. These are the ones that want to come in and say, this has been going on for 3-4 days. They're coughing up some green secretions. We really need those antibiotics. It can last up to 10 days. They can cough for up to 2 to 3 weeks. We have to educate them on that and recognize, once again, that prudent prescribing. Basically, reinforcing that that colored sputum does not mean that it's infectious. Now, when we're seeing the acute bronchitis, I think I already said, is rarely bacterial. 90% of the cases are viral. And you've heard me say 10 times, are we prescribing antibiotics? You can just shake your head. No, we're not. But once again, we have to maintain a relationship with our patients, maintain a relationship with our parent. So we've been challenged to have that open-ended communication to be able to reinforce why we're not prescribing. Even though we sit here and say this over and over again, and I can tell you I've been in the position myself where I've really been torn and probably prescribed when I should not have based on the situation and the pushback that I've gotten. In the United States, we prescribe antibiotics twice as much to the pediatric patients. Not needed. Increasing resistance. Not going to be effective when we need it. So what are the signs and symptoms? They're coming in with that cough. The mucus can be clear, it could be green, it could be yellow. And basically, there's chest tightness and some pain. They may have some fever, some body aches, and sore throat, runny nose, shortness of breath, headache, and fatigue. Those are all some of the symptoms that we can see with that acute bronchitis. So we can see where that parent would think they need to be treated. They're struggling. My child is having a hard time. These are some of the associated viral infections as we're looking at our differentials. It could also be allergies, reflux. All of those things can be contributing to that patient presenting with the symptoms. So with this patient, we're looking at it being self-limited, right? So it's going to resolve on its own. We don't typically do a chest x-ray. If they're continuing to cough beyond 3 weeks, because I said they can cough up to 2 to 3 weeks, then we may consider a chest x-ray. Otherwise, we're going to provide supportive care, rest, antipyretics, hydration, and avoidance of smoke. But guys, this becomes difficult now because we're telling people to stay home if they're not feeling well. Now we have to differentiate in the schools and let them know that this is not infectious. So we have to, sometimes send a note with our patients saying, seen, not infectious, please allow them in school, because they need to be in school. And we don't need to prescribe antibiotics. So once again, we already talked about that over and over again. So about 2 weeks into treatment, if they're still being symptomatic, we may consider it in regards to antibiotics. Albuterol is something that we can use to treat the symptoms with the wheeze and the rhonchi, recognizing that in the patients, 0.1 to 2 milligrams per kilogram twice a day. If we're using it for more than 5 days, we have to be cautious. We can look at potentially an inhaler. If we're looking at it 4 years and older, that's something that can go to school with them. We can write a script to have it at school. They can use it appropriately. We also want to train them on how to use it, or at least train the parent. Because the kids who'd come to my clinic running to use their inhaler, they'd grab the inhaler, they'd go, and they'd run out. Not effective at all. So reinforcing education. I'd slow them down, say, first time they caught me every time. Second time I knew, let's stop, let's do this the right way, and then send them on. And then the nebulizer, based on age and weight. I can tell you in school districts initially, when COVID started, we did not use nebulizers in the school because we were concerned about aerosols in the air and how long did we need to close down a room. So we are now back in a position where we can use the nebulizer. So as we are striving to keep kids in school and not prescribe when it's not needed, it's okay for us to write to have these things in school with the patient. And then the bronchiolitis, and I already talked about it a bit, lower respiratory tract, 50 to 70% is that RSV. Signs and symptoms, wheeze, tachypnea, dyspnea, low-grade fever, the sets dropping less than 93%. What are we treating them with? Isolation, because it's contagious, humidified air. Most of them are not hospitalized, right, unless they're that 1-year-old or that 2-year-old who has some significant problems. Antipyretics. What about steroids? I know when I was a young nurse, everybody with RSV got steroids. What do you guys think now? Not recommended. Now, are we still doing it? Sometimes we throw spaghetti on the wall to see if it'll work, if it'll make a difference. It's not recommended, though. The racemic epi is not part of the treatment plan when we're looking at actual treatment plans. You may still see it happening, obviously racemic epi in the hospital setting, but it's not part of the recommendation at this point. All right, I think I talked too fast.
Nope.
Any questions that you guys have?
We have any questions in the room?
All right, so how many of you guys treat pediatric patients while Mona's looking for? All right, so let's start here, because I have 15 minutes, so I'd love to get you guys engaged and share any knowledge, because one of the things I stressed is what we're seeing in the presentation of these disorders is that it's varying by region. So what are you seeing in your clinic, your arena? And obviously, Mona, if you get a question, please interrupt me at any point. What are you seeing with your pediatric groups? You're like, me? I was like, I'm calling on you, I'm sorry. Yes, sorry.
Our bad season was about a month ago in December, I would say. We had some RSV. I don't think RSV hit our area very hard. Tons of flu. We have a couple, we seem to, I work in a small town, so we'll have a COVID pop, and for 2 weeks you're like, oh, COVID, and then it goes away for a couple weeks, and then you're like, oh, COVID. Somebody had a big party apparently, and popped it up. I haven't, in my office, we probably manage 20,000 patients probably. I know personally I haven't had a hospitalized patient with COVID, pediatric or adult, probably since January. So I just don't think in our area. No, we don't have great vaccination rates, but everybody has had it some 2 or 3 times now. So I feel like it's become very manageable.
And that's reinforcing what we're talking about, that potential change where it's going to become more of an occurrence, and then we're just going to watch out for those high-risk people. Who else would like to? Thank you. Yes, Mona, I'm sorry, to the right.
Hi, my name is Lori. From the Midwest, St. Louis, and I work in an urgent care that's affiliated with a hospital, so we've had no supply issues. And what we've seen most recently, we did see for the pediatric patients, the RSV, we have the fourplex, so we would send that off. Most parents wanted that, and we would get the results back within 24 hours because we are affiliated with the hospital, so 24, maybe 48 hours at the most. But the big thing was we saw the RSV, the COVID, and influenza A and B was very small. The B was very small, but it came about a couple weeks, 2 weeks after the A's were, surging and starting to come down and almost not present. The big thing is we see COVID go away and not in numbers, but then usually within about 2 to 3 months we see like another rise. Whether or not it's them coming back to school or not is not really a pattern that we're seeing. This last week we saw on an average of 2 to 6 COVIDs a day, and it would be anywhere from small kids under the age of 5 and all the way to the ages of like 70s and 80s. So it wasn't specific to any population. It was like across the spectrum, and that's basically what we've been seeing. But with the kids, they ran that course of RSV, then influenza A, very few Bs, and then the COVID just seems to always be around.
How about hospitalizations?
I can't say that being, in the urgent care and not over at the hospital, and our hospital isn't a strong pediatric hospital, I would say, but as far as like our city hospitals, from what I understand, they have been at their max a lot of times with COVID, and the influenza A was really, really strong. RSV for the very young, of course they saw, but other than that, in fact, there were times when they're like, we're really at our max, and if you don't need to send them, then understandable, so.
Good, and that's kind of what I wanted to reinforce today is her story of what we saw in regards to that influenza, the COVID, and the RSV, and maxing out the hospitals that are already strained, having to divert some of the other patients. So that's why we thought it's important to kind of bring it to the table, so as we look at it next season, we know that, okay, this is not abnormal. How can we start planning for the new norm that's not quite predictable? Anyone else want to share their experiences?
Yes, we have a few questions. So
Oh, I'm sorry.
that's okay. So they say, I thought if a patient tested positive for flu, excuse me, they were out of school for 5 days, but some patients test positive and only run a very low-grade fever. How long should they stay out of school?
We should go with the 5 days, and that's a great question, guys, because we have to wait until they're done with the medication. So once the medication is done, and then fever-free. So thank you for that question. That's an excellent question.
Okay, what are potential adverse reactions to Synergis?
So the risk and the benefits, we look at that, obviously being more significant, the benefits far outweigh the risk. Let me find my little cheat sheet, and I'll answer that with my next session because I don't want to speak out of turn in regards to the Synergis, recognizing that it is primarily used in that younger population group. But let me think on that one for a moment. I'm going to honestly say, I don't want to say the wrong thing there.
Okay, can you comment on RSV season?
So RSV season in the past has started in November and extended to February. What we saw in 2021 is it started as early as October and extended far into March and April. So that's literally before COVID, before anything, being in pediatrics for the last 20 years is when we saw it. And with that, like I said, anybody under the age of 2, it was a cold. We didn't care. It's RSV, it's cold, their stats are good, they just have a cold. And then under 2, we didn't worry too much unless they had comorbidities, if they had cardiac issues or asthma or something. Then they may end up hospitalized if their sets are dropping. But that 1-year-old, especially anyone under 3 months old, was almost an automatic hospitalization with RSV is kind of what we expected, especially if they were preemies. So that's where we've seen a change in it, and now we want to treat it aggressively or at least recognize it so that 65-year-old, because we never talked about 65-year-olds with RSV, it was a cold, but now it's a different environment. I hope that answers it. So in regards to the treatment, starting earlier, because Synergis, like I said, it's not going to treat RSV. It's just preventing. So we're already looking at some preventive medications for it. So we would start before the season. Literally, in the past, it'd be like in October, November, and stop in February after 5 months.
Okay, thank you. Can we comment on why Native Americans and Alaskans are at higher risk groups?
Just basically the socioeconomic level, the social determinants of health, and decreased immunity. Maybe working in that, they're in the smaller community, but they're having a higher risk for adverse effects.
Okay. In terms of COVID-19, do you have the same approach to routine childhood immunizations?
Yes, except we have to be a lot more careful. Remember how I mentioned the World Health Organization and the CDC and how we're rebuilding our trust? The community's rebuilding their trust with us. So we've had more people decide not to vaccinate, not to immunize because of this. So we would still follow the same guidelines, and depending on the state though. Some states are saying, once again, I'm gonna not go too deep because we can have a whole conversation on it. Some areas are saying immunizations or vaccinations of children for COVID is not needed. So we're not gonna go down that rabbit hole, but just recognize the information that parents are getting is not always consistent. And as we sit and we talk about, most of the kids are not having severe disease and that they're not dying. Maybe they're not wrong. We just may not have that literature. Does that make sense, hopefully? So it's one of those unknowns that if I had children, I'm not sure that I would push it either.
Okay, thank you.
Young children.
Should Paxlovid be taken again for people with rebound symptoms of COVID-19?
No. So they wouldn't, in most cases, they're not redoing it, re-prescribing it. Most of the cases we've seen, once again, the Paxlovid helped, we're hoping, with the severe disease, but they may have had rebound because of the treatment with the Paxlovid also. So,
Is there a time frame with which we would not retreat? Like after 3 months we retreat, or?
that I don't have an answer to because I don't know that that's been addressed in regards to retreatment with the Paxlovid.
Okay.
Thank you.
Once a year.
And it's not based, and that's why I didn't want to answer, because it's not based on the need, it's based on coverage. And I haven't seen consistent literature on to treat or not to treat. But that's good to know that insurance will only cover it once a year.
Great. And our last question is about, you commented on treating caregivers. So they kind of want to know the logistics of that if you're in an urgent care setting. Do they now need to, the caregivers need to re-register and create a visit, or do you kind of combine that with the visit of the sick child?
If you decided to treat, I would encourage you to have a whole separate visit. I don't know anyone who's doing that. It's in the literature that's suggested, but I haven't seen it in actual practice. You've done it? Yes, tell me what your experience was. I'm sorry.
I'm coming. Making me run. Who was it?
So we work in a community hospital. You said you do it also, right, Kim? And I try to do it every time, especially if they have elderly or other young children in the house. And most of our patients are seen at our clinic also because they're undocumented or uninsured or underinsured. And so I'll ask them, if they would like to receive prophylaxis, or if they're symptomatic, if they would also like to receive treatment. And if they say yes, if they give me permission to access their chart, then I'll go in the system and we have Epic. So I do an orders only encounter and I just put in the orders. It's a little bit more of a sticky wicket if it's a kid like under 5 and they haven't had a more recent encounter, and you don't know how much they weigh, that can be a little bit more difficult. But that I would say is a rare circumstance. And I know that a lot of our providers at our clinic don't do it because it takes a little bit of time, but it's like, depending on how big the family is, maybe 5 minutes. It's not all that. And I know that I would want somebody to do it for my family. So, and I saw a case where, there was twins with severe asthma and one of them was seen in the emergency room with influenza, and they treated one kid and not the other. And the pediatric pulmonologist and I were both just like banging our heads against the wall, like, what the heck?
And I think a lot of times it may go down to something, unfortunately, as billing. So I know that if I had done it in my urgent care, my provider would have expected me to completely do an assessment and bill appropriately. And that may be a factor that's inhibiting some people. Time also, but not good excuses. And I'm very happy that you're in that community setting and able to do that too. It's good. Anyone else?
You may also run into issues where the family members that need to be treated are not there. So you can't do the whole assessment. If you don't have a chart on that person, it may not really be a great idea to prescribe for them. I work in only pediatric settings, so like if grandma needs treatment, we recommend you contact your healthcare provider who really would be a good idea for you to be prophylaxed, but we would not write the prescription for the grandmother.
And that's great. Thank you guys for helping to identify some of the barriers to the recommendations, because I know that would be a barrier for me. I know Or my personal, well, I don't even know of my personal practice because we don't know what kind of health conditions they have going on. I personally would want to assess somebody before I prescribed in an environment where people want to sue, especially with treatments like that. Yes.
Hi, good morning. Can you speak to the recent research on croup, please? I don't treat pediatrics, but I am particularly interested in this topic because my 7-year-old has it repeatedly. What does the recent research show on this? Thank you.
Believe it or not, it hasn't changed much. So the laryngeal tracheobronchitis is what we're still calling it. The treatment is, based on if it's mild, moderate, and severe. Once we have the mild, it's just supportive care. So the things you're doing is looking for any have they been exposed? Are they catching a cold? Is something else going on? Using the warmed, cool mist humidifier. So that's what we're looking at with the mild cases. Moderate is when they start looking at treatment with a steroid. And then severe is when you're hospitalized and doing some, more severe treatment. And still steroids. It's all supportive care, hydration, monitoring, and steroids. So nothing, unfortunately, hasn't changed much in regards to the croup.
Thank you so much.
Now, I haven't researched it this year, though, so don't quote me if there's been some changes this year. As of last year when I researched it, those were still the same treatment plans.
Thank you so much, Dr. Ernewein. We're going to take a 15-minute break. We'll be back here at 9:45.